I want to tell you a story about a man named Robert. Robert lived in a quiet, sun-drenched neighborhood in Orlando, Florida. At 72 years old, he was the kind of man we all hope to be, sharp as a tack, fully independent, and deeply active. Every single morning, like clockwork, you'd find him walking 4 miles along the lake, greeting his neighbors with a firm wave. He lived alone, managed his own finances, and took pride in the fact that he hadn't spent a single night in a hospital bed in over 30 years. Then came a Tuesday morning in October. Robert went in for what he called a routine tune-up, a simple annual physical. He felt great. No cough, no chest pain, no fatigue. But during the exam, his doctor said something that sounded so responsible, so cautious. "Robert, you're doing fantastic, but since we haven't looked at your lungs in a few years, let's just get a quick chest x-ray, just to be safe. It's just a standard screening for someone your age." Robert didn't think twice. Why would he? It's just an x-ray, right? It's just a picture. He walked into the imaging center, a healthy, independent man. He left with a referral. That quick x-ray showed a tiny, ambiguous shadow, a spot so small it likely would have never caused him a single symptom in his lifetime. But once you see something, you can't unsee it. The medical machinery began to grind. That x-ray led to a CT scan. The CT scan led to a needle biopsy, and that biopsy, meant to protect him, caused a collapsed lung and a severe infection. 6 months later, I met Robert. He wasn't walking 4 miles anymore. He wasn't even walking to his mailbox without a walker and a portable oxygen tank. The original spot on the x-ray? It was benign. It would never have touched him. But the process of finding it, the screening itself, is what took his independence away. I'm here today because this is the conversation your doctor probably hasn't had with you yet. The math of medicine changes as we age, and nobody tells you when the rules flip. If you are over 65, the very tests meant to save you can sometimes become your greatest risk. Before we dive into the 5 specific X-ray tests you need to be wary of, please take a moment to subscribe to the channel. We are building a community here dedicated to aging with dignity and making informed choices. And your support helps us bring this vital information to more people. Now, let's talk about why the medical rulebook you followed at 50 is officially outdated the moment you hit 65. To understand why what happened to Robert is becoming so common, we have to look at a fundamental truth that the medical industry rarely admits. Medicine is a game of math and probability. And the math you were taught when you were 40 or 50 years old, it officially expires the moment you blow out the candles on your 65th birthday. Think back to when you were in your late 40s. At that age, the medical logic was simple and effective. Early detection saves lives. If you find a microscopic abnormality in a 50-year-old, you treat it aggressively because that person potentially has 30 or 40 years of life ahead of them. In that context, finding something small makes perfect sense. You have the time to recover from surgery, the resilience to handle radiation, and the biological runway to benefit from the intervention. But here is the uncomfortable truth that remains a secret in many doctors' offices. Somewhere along the way, the medical system forgot to update the rule book for people who are 65, 75, or 85. In an older body, the early detection logic starts to crumble. Why? Because biology changes. As we age, many conditions, including certain types of tumors that an X-ray might pick up, behave differently. They grow much slower. In many cases, a 75-year-old might have a small growth that would take 15 years to ever cause a single symptom. Statistically, that person is far more likely to die of natural causes or an unrelated issue long before that finding on an X-ray ever touches them. When we screen aggressively in this age group, we aren't always saving years. We are often just medicalizing the years you have left. The same screening that buys a 45-year-old 20 extra years might only buy an 80-year-old 6 months. and those 6 months are often spent in a hospital bed recovering from the very treatment meant to help them. The medical system is slow to catch up to this reality. Guidelines are often written by researchers looking at middle-aged adults, and then those same rules are blindly applied to seniors. This creates a dangerous gap. It leads to a culture where doctors feel obligated to order the test because it's the protocol, and patients feel scared to say no because they've been told for decades that screening is the responsible thing to do. But being responsible at 65 means shifting your focus. It means moving away from hunting for every possible abnormality and moving toward preserving your function and your independence. Before we look at the specific X-rays that can trigger this, we need to talk about the most dangerous phenomenon in modern geriatrics, the cascade effect. In modern geriatrics, there is a term we use to describe the most underappreciated danger in medicine. We call it the cascade effect. Think of a single pebble tossed into a still pond. It creates a ripple, then another, and another, until the entire surface is disturbed. In medicine, specifically for those over 65, that first pebble is often a routine X-ray. The cascade effect is what happens when a test intended to be helpful starts a chain reaction of interventions that eventually leads to harm. It starts innocently enough. You feel fine, but your doctor sees a borderline result on a routine scan and says, "Let's just take a closer look." That closer look is where the trap is set. Once anything is found on a scan, the medical machinery starts moving with a momentum that is incredibly hard to stop. Your doctor feels a professional and legal obligation to act on that finding. You, as the patient, feel a natural sense of fear. Who wouldn't be scared when a doctor says they found a shadow or an abnormality? So, you agree to the next step. Let's look at how this chain actually plays out in real life. That closer look usually requires a biopsy, a procedure where a needle or a tube is inserted into your body to grab a piece of tissue. But in an older body, even a minor biopsy carries risks. Maybe the biopsy causes a small internal bleed. That bleed now needs 24-hour monitoring in the hospital. The stress of being in the hospital and the medication given for the bleed might trigger an irregular heartbeat. Now, you aren't just a person with a shadow on an X-ray. You are a patient with a heart issue. To treat the heartbeat, the doctor prescribes a new medication. But that medication has a side effect. It makes you feel slightly dizzy when you stand up quickly. One night, you get up to go to the bathroom, you feel that dizziness, and you fall. That fall leads to a hip fracture. I have watched this exact chain of events play out more times than I can count. A perfectly functional, independent 72-year-old walks in for a checkup, and 4 months later they are managing 3 new diagnoses, 4 new prescriptions, and a deep-seated fear of leaving their own home. This risk is real. It is documented, and yet it is almost never part of the conversation when a doctor hands you a referral slip. Today, we are going to change that. We are going to look at 5 specific X-ray tests that frequently trigger this dangerous cascade. Let's start with one of the most common, almost invisible hurdles in the American healthcare system, the routine chest X-ray before a minor surgery. Imagine Mary. Mary is a 69-year-old retired schoolteacher from Austin, Texas. She's been dealing with a nagging pain in her right knee for years, and she's finally decided to get a partial knee replacement so she can keep up with her grandkids at the park. Her heart is strong, her lungs are clear, and she hasn't had a cigarette in 30 years. But during her pre-op appointment, the surgical coordinator hands her a stack of papers and says, "We just need a quick chest X-ray to clear you for the anesthesia. It's standard protocol." Now, on the surface, this sounds like the height of caution. Who wouldn't want their doctor to be thorough? But here is what the data tells us, and what Mary was never told. If you have no symptoms, no cough, no shortness of breath, no history of heart disease, a routine chest X-ray before surgery is almost entirely useless. Study after study has shown that for asymptomatic seniors, these just-in-case X-rays practically never change the surgical plan or make the anesthesia any safer. But while the benefit is near zero, the risk of starting a cascade is incredibly high. In Mary's case, the X-ray technician captured a tiny, harmless irregularity, a bit of scar tissue from a bout of pneumonia she had 20 years ago. In the medical report, it's labeled as an inconclusive finding. Suddenly, Mary's simple knee surgery is put on indefinite hold. Her surgeon, wanting to avoid any liability, tells her she needs a high-resolution CT scan of her chest before they can proceed. This is where the emotional toll begins. Mary was mentally prepared for a knee surgery. Now, she's sitting at home in Texas, terrified that she might have lung cancer. The CT scan involves a significant dose of radiation, much higher than a simple X-ray, and it leads to a referral to a specialist. 2 weeks of anxiety, 3 extra copays, and a battery of unnecessary follow-ups later, the specialist concludes exactly what we knew at the start. Her lungs are fine. But Mary isn't fine. She's stressed, she's exhausted, and her knee surgery was delayed by a month, during which she was less mobile and more prone to a fall. When your doctor orders a routine chest X-ray before a procedure, you need to ask, if I have no symptoms, how will this picture change my care? If the answer is just, it's policy, you have the right to push back. Don't let a standard protocol turn a routine fix into a medical nightmare. Now, let's move to a part of the body that seems to keep more seniors in the doctor's office than almost anything else, the lower back. If you are over 65 and you haven't felt a twinge of back pain, you are in a very lucky minority. But there is a massive difference between managing back pain and imaging back pain. Meet James. James is a 68-year-old retired carpenter from Chicago. He spent 40 years building homes, and his back carries the history of that hard work. One morning, the stiffness in his lumbar spine felt a little sharper than usual. Like most responsible people, James went to see his primary care physician. He wasn't looking for surgery, he just wanted answers. He asked the question we all ask, can we just get an X-ray to see what's going on back there? Here is the problem. In a person over 65, an X-ray of the spine is like taking a high-definition photograph of a 1960s classic car that's been driven across the country 10 times. You are going to see rust. You are going to see dents. In medical terms, the radiologist's report will use scary-sounding words like degenerative disc disease, spinal stenosis, or osteophytes. To a 30-year-old, those words might mean a serious injury. But to a 65 or 70-year-old, those findings are often just the internal version of wrinkles or gray hair. They are normal signs of a life well lived. However, once those words are printed on a report, the cascade effect kicks in with a vengeance. James read the word degenerative and felt like his spine was crumbling. His doctor, seeing the X-ray report, felt he couldn't ignore it. This led to an MRI, which showed even more abnormalities that were likely there for 20 years without causing a problem. From the MRI, James was referred to a spinal surgeon. Within 3 months of that first simple X-ray, James was being talked into a spinal fusion surgery, a major procedure with a long recovery and significant risks of infection and loss of mobility for someone his age. The tragedy is that research shows for most seniors with chronic back pain, movement, physical therapy, and anti-inflammatory management are far more effective and infinitely safer than the surgical path triggered by a routine X-ray. If you are over 65 and dealing with back pain, before you agree to that X-ray, ask your doctor, will this picture change my treatment, or will it just give us a scary label for something that is a normal part of aging? Remember, treating the image on the X-ray is often the fastest way to lose the ability to move your actual body. Now, let's talk about a place most of us don't associate with major medical risks, the dentist's chair. We've been told our whole lives that dental health is the gateway to overall health, and that's true. But There is a specific type of imaging, the panoramic X-ray, or OPG, that is frequently ordered for seniors over 65 as a routine part of an annual checkup, even when there's no pain or specific issue. Meet Martha. Martha is a 70-year-old grandmother living in Phoenix, Arizona. She's meticulous about her health and never misses a cleaning. During her last visit, the dental assistant said, "Martha, it's been a few years since we did a full panoramic scan of your jaw. Let's just get one today to make sure everything looks good under the surface." In a younger patient, this scan might identify a wisdom tooth issue or a developing cavity. But in Martha's 70-year-old jaw, the X-ray showed something else. A small, asymptomatic thinning of the bone, something that had likely been there for a decade and was never going to cause her a single day of pain. However, once that finding was on the screen, the dentist felt he had to refer her to an oral surgeon. The surgeon, being thorough, suggested a bone biopsy to rule out anything serious. Suddenly, Martha, who just went in for a routine cleaning, found herself facing a surgical procedure in her mouth. The biopsy caused a localized infection and significant nerve pain that lasted for months, making it difficult for her to eat her favorite foods or speak clearly to her grandkids. The reality is that after 65, the goal of dental care should shift toward comfort and function, not hunting for asymptomatic bone irregularities. If you aren't experiencing pain, swelling, or difficulty chewing, a full panoramic X-ray might be looking for problems that don't need to be solved. Before you let that large X-ray machine spin around your head, ask your dentist, "Is there a specific symptom we are investigating, or is this just a routine picture?" If it's just routine and your mouth feels fine, you might be better off saying, "Let's wait." Remember, the goal is to keep you eating and smiling, not to start a surgical journey you never asked for. Now, let's talk about something that affects millions of Americans every single day, that burning sensation in the chest we call acid reflux or heartburn. If you are over 65, your digestive system naturally slows down, and occasional reflux becomes more common. But there is a specific diagnostic path involving X-rays that can quickly turn a minor annoyance into a major health event. Meet Sarah. Sarah is a 73-year-old retired nurse living in Charlotte, North Carolina. She's always been proactive about her health. Lately, she noticed that after her evening meal, she was getting a bit more heartburn than usual. She wasn't losing weight, she didn't have trouble swallowing, and she wasn't in severe pain. But at her next checkup, she mentioned it to her doctor. Instead of starting with simple lifestyle changes or mild over-the-counter options, the doctor said, "Let's get a barium swallow X-ray just to see how your esophagus is moving." To Sarah, this sounded like a harmless test. But for a 73-year-old body, the barium swallow is far from simple. First, there's the preparation and the test itself, drinking a thick, chalky liquid that can be difficult for some seniors to manage. There is a real risk of aspiration, where that liquid accidentally enters the lungs, which can lead to a serious infection. But the real danger for Sarah was the finding. The X-ray showed a small hiatal hernia, a condition where the top of the stomach bulges through the diaphragm. In a woman of Sarah's age, this is incredibly common and often completely asymptomatic. But once it was documented on that X-ray, the cascade effect took over. Sarah's doctor, seeing the report, immediately prescribed a high-dose proton pump inhibitor, PPI. These medications, while helpful for some, carry significant risks for seniors, including an increased risk of bone fractures and interference with nutrient absorption. Within a month, Sarah started feeling dizzy and weak. The doctor then suggested a surgical consultation to repair the hernia. Suddenly, a woman who just had a bit of post-dinner heartburn was being prepared for a general anesthesia procedure she never needed. The stress of the upcoming surgery and the side effects of the new medication caused Sarah's blood pressure to spike, leading to even more prescriptions. If you are dealing with mild reflux, before you agree to a barium swallow or any GI imaging, ask your doctor, Is this test necessary before we try lifestyle modifications or milder treatments? And most importantly, ask, if this scan shows a common age-related change like a small hernia, will we actually treat it surgically? Don't let a routine X-ray for heartburn turn your digestive health into a surgical project. Finally, let's talk about something that almost every senior in America deals with at some point: stiff joints and creaky knees. It's that sharp pang when you get out of a car or the dull ache after a long walk in the park. In our culture, we've been conditioned to think that if something hurts, we need a picture of it to fix it. But when it comes to your joints after 65, an X-ray can be a very misleading storyteller. Meet George. George is a 71-year-old retired mail carrier from Denver, Colorado. He's spent his life on his feet, and naturally, his knees have started to talk to him in the mornings. It's not a debilitating pain. He still gardens and plays golf. But he wanted to be proactive. He went to his doctor and asked for an X-ray of both knees just to see how much cartilage is left. Here is the catch. If you take an X-ray of the knees or hips of almost any active 70-year-old, you are going to find osteoarthritis. You will see narrowed joint spaces, bone spurs, and signs of wear and tear. On paper, it looks like a disaster. But for George, those findings didn't actually match his lifestyle. He was functioning just fine until he saw the X-ray. Once George saw the image of bone-on-bone contact, his psychology changed. He stopped golfing because he was afraid of wearing out his joints further. His doctor, following the imaging rather than the patient, referred him to an orthopedic surgeon. Before he knew it, George was being scheduled for a total knee replacement, a massive surgery with a grueling recovery and potential risks of blood clots and infections for someone his age. The medical truth is that your X-ray is not your destiny. Many people with terrible-looking X-rays have zero pain and full mobility, while others with clean scans suffer greatly. By focusing on the X-ray, we often end up treating the picture instead of the person. Research consistently shows that for minor stiffness, physical therapy, weight management, and low-impact movement are far more effective at preserving quality of life than the surgical path triggered by a routine scan. If your joints are stiff, but you're still moving, ask your doctor. Since I'm still active, will this X-ray change my treatment plan, or will it just give us a reason to stop doing the things I love? Don't let a snapshot of your wear and tear convince you that you are broken. I know exactly how it feels to sit in that exam room. You're often wearing a paper-thin gown, the room is cold, and your doctor is staring at a computer screen, clicking through boxes. You don't want to be difficult. You've spent decades trusting the white coat, and you don't want to come across as someone refusing care. But I need you to hear this. Asking questions is not refusing care. It is participating in your care. There is a profound difference. The medical system, especially in a busy place like New York or Los Angeles, is set up for speed. A doctor can order a screening in 30 seconds, but having a nuanced conversation about whether that screening makes sense for you takes 15 minutes. Minutes that often don't exist in a standard appointment. To protect your independence, you must be the one to start that conversation. Here are the 5 questions you need to bring to your next appointment. First, ask, what are we looking for, and what will we do if we find it? This single question forces the doctor to think ahead. If the answer is, we probably won't do anything aggressive because of your age, then you have to ask why you're doing the test at all. Second, ask, what is the specific risk of this procedure for someone my age and my current health? Age-specific risks like cognitive changes from anesthesia or dehydration from PrEP are rarely volunteered. You have to demand those numbers. Third, ask, what happens if we watch and wait instead? Active surveillance is a legitimate, evidence-based option. It is not giving up. It is choosing wisely. Fourth, ask, is this guideline based on research that actually included people my age? Many medical rules were written for 50-year-olds and simply extended upward without proof that they work for an 80-year-old. And fifth, ask, what would you recommend if I were your own mother or father? I've asked this of my colleagues for years, and you would be shocked at how often the answer changes when the patient becomes family. Bring these questions written on a piece of paper. If your doctor dismisses them rather than engaging with you, that tells you something very important about whether that doctor is the right fit for this stage of your life. We have covered a lot of ground today, from routine chest x-rays to the hidden complexities of imaging your joints. But if there is only one thing you take away from our conversation, let it be this. More medicine is not always better medicine. As we cross the threshold of 65, the philosophy of our care must shift. We have spent our lives in a medical system designed to hunt down every microscopic abnormality, but in our senior years, that hunt can often cost us the very thing we are trying to protect, our independence. Real medicine after 65 isn't about having the most pristine X-ray report. It's about preserving your function, your cognitive sharpness, and your ability to live life on your own terms. The cascade effect is real, and it starts the moment we agree to a test without asking why. I have seen too many patients like Robert who walked into a clinic healthy and left diminished, not because of a disease, but because of a series of standard protocols that didn't account for his age. You deserve better than a rubber stamp referral. You deserve an honest, individualized conversation with a doctor who treats you as a person, not as a collection of scans. I want you to go to your next appointment with your head held high and your list of questions in hand. Remember, you are not being difficult. You are being diligent. You are the CEO of your own health, and your doctor is your lead consultant. Before we go, if this information has empowered you or made you look at your healthcare differently, please subscribe to the channel. Our goal is to build a community where we can all navigate the complexities of aging with dignity and facts. Share this video with a friend or a family member who might be facing these decisions right now. This conversation doesn't happen nearly enough in the waiting rooms of America. And finally, I want to hear from you. Has a routine test ever led you down a path you didn't expect? Your stories help others realize they aren't alone in this. Please remember, the information shared today is based on current research and clinical experience, but your situation is unique. Always talk to your personal physician before making changes to your care. Stay strong, stay informed, and most importantly, stay in charge of your own health.